Okay, now this is going to be part 2 of back pain, Rogers' theory of spinal degeneration, ischemic and biochemical components. So, again, you got to see this diagram here. Here's a lumbar spine. Lumbar spine got 5 vertebrae, L5, L4, L3, L2, and L1 above. The lumbar arteries come off the abdominal aorta, and they run mid-height of the vertebral body, and then they drop a little branch to the lower end plate, one to the upper end plate, and that supplies the disc with blood supply. There's one on each side of the spine. I'll show you over here what it looks like. So when you have blood flow, the red ones will consider these to be normal arteries, all right? But we'll consider these blue ones to be clotted, thrombosed lumbar arteries, blocked up with atherosclerosis, for example. And you'll get more severe degeneration on the side where the lumbar artery is thrombosed or severely stenosed. And when that happens, you'll get more severe degeneration of the disc. And this leads to what is called degenerative scoliosis. Again, this is something I see every day. Okay, so you get narrowing more severe on the side where there's complete occlusion of the lumbar artery in comparison with just a little bit of decreased blood flow. And that will lead to degenerative scoliosis. Okay. So that's an important point. You're going to see this a lot, and this causes a lot of back pain as well. It makes everything more difficult to do a procedure on the patient, to do a surgery on the patient, to interpret their MRI. So this is the ischemic theory of degenerative scoliosis right there. It's all part of the same thing. What I'm going to show you is my explanation of the spine explains tons of things. It's going to explain all these common degenerative conditions of the spine and show you that they're all the same thing. Degenerative disc disease, DDD. DISH, diffuse idiopathic skeletal hyperostosis, okay? OPLL, ossification of the posterior longitudinal ligament. OLF, ossification of the ligament inflavum. Bostrup's disease, fusion of the spinous processes. I'm going to show you how it's all the same thing. Okay, now here's just a regular x-ray showing you degenerative scoliosis. Same thing we just showed before on a CAT scan, which is like an individual image through an entire cross-section of images, okay? And so this is a patient who had a laminectomy before, but you see the same general concept, more severely tight right here and right here, because you're going to have occluded lumbars right there, okay? All right, now I'm just going to introduce you to MRI, because we're going to be talking about MRI in some of these pictures. There's a few simple concepts to get, and what I'm giving you is like the most important thing you could possibly know about MRI. This is a T1 scan. So there's two things in MRI. The foundation of all MRI is T1 and T2, T1 and T2. And it's like if you were going to study zoology, there's an animal kingdom and a plant kingdom. So T1 MRI, fluid is dark. You have to know that, okay? Fluid is dark on T1. You have to know that. Okay, you can imagine the letter D, one flat downstroke, and you make a D off it. Dark, fluid, dark. That's the most important thing you know. I don't care what any other book or any person sees. I've seen a million MRIs. Fluid is dark on T1. You have to know that. Okay, on T2, fluid is bright. You can remember the letter 2. The top of a 2, when you write the number 2, looks like the top of the letter B. 2 is bright. So on T2 sequence, fluid is bright. Okay. In general, for most things, the most important image of a lumbar spine MRI or a cervical spine MRI is going to be the sagittal T2. So sagittal means a cut from side to side, okay? As if you're like slicing a loaf of bread from side to side. That's how you slice the spine to make the individual images. It's the same thing for CAT scan as it is for MRI. Okay, so because the T2, the reason it's so easy to interpret is the disc is dark and the CSF is bright, so you can very clearly see the disc when it bulges into the central spinal canal. This is the lower part of the thoracic spinal cord. It's called the conus medullaris. The nerves that come off, that's called the cauda equina, like a horse's tail. Okay, and they're going to work their way down and then exit through foramen at the side of the vertebrae. Okay, the T1, what's it good for? It's good for that it has high fat signal in the vertebral body. So if the person has metastatic tumor, that will replace the fat, and you'll see a low signal lesion in the vertebral bodies. That's the main thing I look at T1 for. Is there any evidence of METs? The other thing is T1 is good for giving IV contrast, because in MRI for everything, you want to increase the signal of the pathology and you want to suppress the signal of the background. So you don't want to give If you're trying to look at the central canal, you don't want to give IV contrast on a T2 because the high signal of the fluid would obscure everything. It'd be like squinting into the sun. But it's good to do it with a T1. And you can even suppress the fat signal. So we call that a T1 fat sat. Fat saturation is the same thing as fat suppression. And that's a really good sequence. We do that all the time for looking at the lumbar spine post-IV contrast. To have abnormal uptake of contrast is enhancement. So by suppressing the background, by having a baseline T1 sequence to suppress the fluid and doing a fat sat, fat suppression sequence, we'll get really good visualization of contrast to pick up any subtle abnormal enhancement. And that's how all of MRI is done throughout the body. Those are the general concepts. Okay. The reason why T2 intrinsically is usually better for things, and you can suppress the fat on a T2, is most pathology has edema, meaning fluid accumulates in the context of inflammation. Remember the mnemonic for inflammation. Inflammatory signs are quite plain: redness, swelling, heat, and pain. Okay, swelling meaning the fluid goes into the air. It's called edema. It's a medical word for fluid-related swelling of something. Okay, so why am I so confident I know I'm right? Because I've seen a bazillion of these. It explains everything. And all my buddies in neurology and spinal cord doctors, physical medicine, rehab, they're all like, yeah, Pete, you're totally right. And also what happened is I tried to submit this to several journals and they won't publish it. And I get pissed off because the journals have become so corrupt. They're basically money-making machines, okay? If you sell spine surgery devices, they'll publish your article. If you, promote spine procedures, injecting steroids and other things, they'll want that. If you promote drugs for treating back pain, the journals will want that. But something like my article shows that you can dramatically reduce spine symptoms by optimizing your diet and your lifestyle. Spine journals don't want that. So I get a little pissed off because, it's hard to publish the truth nowadays. The truth is being hidden everywhere, but it's seldom available. And my logic was just obvious. Lack of blood flow causes problems everywhere else in the body. Why wouldn't it cause a problem in the spine? And when I started looking for the correlations, it all made sense. There were some older papers showing degenerative disc disease, is associated with increased atherosclerosis of the abdominal aorta, but that was about it. I put this whole system together and went beyond that to give a functional mechanism for everything, and it's going to explain tons of stuff. Okay, and I also can tell you, I see a lot of back pain patients, and a lot of them are so simple-minded, it's pathetic. They just think, if only I could get spine surgery, then I would get better. What they don't understand is their whole spine's abnormal. Their whole spine is ischemic, okay, with weak ligaments. You can't operate on the whole spine. It's a little bit like coronary artery disease. Coronary artery is always diffuse. The only way you're going to fix it long-term is you have to improve blood flow, and you have to have better ligaments. And the way you're going to have better ligaments is by avoiding things that are toxic to ligaments. I'll go into all of that, but it's kind of obvious when you start thinking about it. Okay, and like I said, I make a joke like Medusa, in the Chronicles of Narnia, where the people were turned to stone. In real life, people do turn to stone inside themselves. They calcify their aorta all up and down, and then they drop their blood flow everywhere, and they start fibrosing, calcifying, and sclerosing things off all over the body. I can tell you this, in the Western world, 9 out of 10 patients, which is the vast majority of the patients, they all have the same diseases. Most of them are overweight, but lots of them, even if they're not overweight, they still have hypertension, and then type 2 diabetes or prediabetes diabetes. Those cause lots of atherosclerosis. Atherosclerosis is a blood clot that plugs up artery. Once you plug up an artery to an organ, it starts to drop its function and die. Okay, as things that die often get calcified. So that's why you see in old people, calcifications all over the place. Lousy looking arteries with atherosclerosis all over the place. And then the organs just degenerate. Okay, that's a typical thing one sees all day long in the Western world. And it always gets treated with drugs and surgery, so the cure rate's about 0%. Okay, here's a little more detail about lumbar spine anatomy. So here would be S1, which is shaped kind of like a trapezoid, whereas L5, lumbar vertebral number 5. S1 would be sacral vertebra number 1. Lumbar vertebral number 5 is going to be relatively sort of square, a little bit rectangular even. This is a Schmorl's node whereby the disc is herniated in the vertebral body. We see those quite often with degenerative disc disease. This right here is a protrusion. So what a protrusion means is typically it's sort of a code word for small disc herniation, meaning the height of the disc herniation does not extend above the disc space height, either above or below. A disc extrusion means that the disc either goes above the disc space height or it goes down below the disc space height. So this would be described on like an MRI report. You know, L4-5, large disc extrusion with extension both above and below the disc space. Now, you can also measure how far posteriorly it goes. Sometimes I'll do that, depending. Large, medium, small is often good enough, but sometimes I'll measure it. This is the fat in the epidural space, and sometimes that can accumulate, especially in obese patients. But these words were chosen because disc herniation is too vague, so this specifies what it is. If you give the height of the disc herniation and the length of it, that's about as precise as you're going to get. And the location of it. Is it in the center? Is it off to the right or to the left paramedian, for example? Okay, here would be an example of a very small disc protrusion or disc herniation, you might call it, okay, at L4-5, all right? Now over here, this is a protrusion because it stays at the height. This is an L3-4 disc protrusion. It stays at the height of the disc, and it extends back, let's say, about 8 millimeters. And you can see it's indenting the nerve roots as they pass downward in the intrathecal space there, okay? So this is something you definitely would not want to do surgery on. This one's kind of borderline. In private practice, they'll probably operate on this. And if the patient's doctor on a salary, they'll probably recommend go for epidural steroids first. That's a bit of a joke. They probably will recommend epidural steroids first in the private sector as well. But this one, discal herniations will sometimes reabsorb, especially if a part of it is a little bit of bleeding, a little hematoma. Okay, now here is a big disc herniation. This is a big extrusion, okay? So the report on this one would be L4-5, lumbar vertebra number 4 and 5, and the disc right here with large disc extrusion extending above the disc space, okay? And the other thing I'm going to tell you is notice how the disc extrusion is bigger than the disc itself. And what you say about these are, a lot of times this is not all disc material. Very often there's a lot of veins in the anterior epidural space, the anterior part of the spinal canal. Anterior spinal canal is called the epidural space, anterior epidural space. And there's a nerve plexus in there. It's called Batson's plexus. But anyways, when a disc herniation happens, it'll sometimes cause a cut of one of the little veins, and you get a little tiny hematoma. So it happens around the disc. So peri means around disc, hematoma, peridiscal hematoma. Okay, and the good news is, even though it looks bad at first, and it can be very painful initially, these typically are reabsorbed very quickly. So if the patient can sit it out, go ahead and maybe do an epidural steroid, but if the patient can sit it out a couple months, these will often virtually almost completely reabsorb. So these patients do really well. So that's peridiscal hematoma. Okay, now here is a picture of the ligaments. The ligament anterior to the vertebrae is called the anterior longitudinal ligament. Longitudinal, could be another word for vertical ligament. Okay, the ligament posterior to the vertebra is called posterior longitudinal ligament, and you need to know that name. That's going to come up. You can look at the abbreviation letters of the acronym PLL, posterior longitudinal ligament. This ligament in the human body is kind of yellow in color, so it's called ligamentum flavum. Flavum means yellow. Okay, ligaments are primarily made out of collagen. Collagen is the most common protein in the body. From 1/3 to 1/4 of all the protein in the body is collagen. And it's wrapped real tight in a triple helix. So there's 3 fibrils wound around each other in a triple helix, and that's the characteristic appearance of collagen. Okay, so the most important thing on this slide for you to get is the fact that this ligament right here is the posterior longitudinal ligament. Okay, and all the ligaments are made out of collagen. All right, now I'm going to show you something pretty cool. And remember how I described my theory initially as being the ischemic theory of spinal degeneration, but I also now call it the ischemic meaning lack of blood flow, and biochemical. I'm going to go into the biochemistry. It's going to be really simple biochemistry, but here is a collagen protein, and here's one fibril of it. You'll notice there's a lot of hydroxyprolines. This is secondary, post-translation modification, meaning that after the protein's initially made, it undergoes modifications. And it gets hydroxylated on the proline residues. That requires vitamin C. So people who don't eat enough fruits and vegetables, they're low in vitamin C, and they'll have a harder time hydroxylating their collagen, so their collagen will tend to be weaker. The next thing to notice is glycine is the yellow amino acid here. A protein is basically like a necklace of amino acids, like beads on a necklace. Each bead would be like an amino acid. So here's glycine, the yellow circle. Every third amino acid in collagen is glycine. You need to know that. That's really important. Every third amino acid in collagen is a glycine. Well, guess what? What do they spray on 70 different types of non-organic food, especially soy? They spray this glyphosate stuff. Well, that's basically like saying glycine phosphate. There's a little more to it than that, but essentially it's like a glycine phosphate. And it's thought that the glycine phosphate is substituting itself for the glycine when the proteins are synthesized. And then it will subsequently distort the shape. The reason why glycine's every third amino acid residue in a triple helix is because it's got the smallest side chain, just a hydrogen. So you can wrap it really tight and make a tight, strong helix. These are like the wrapped around metal cords you see on the Golden Gate Bridge, suspension bridge. They're freaking strong, okay? That's what you want your collagen to be. But if you distort the shape of it with glyphosate substituting for glycine, it's going to be a lot weaker, the ligament. And if you don't have vitamin C, so you can't hydroxylate it, fluoride in your tap water also damage it. Fluoride in toothpaste leads to damage of these ligaments. Smoking cigarettes leads to damage of these ligaments. Drinking alcohol damages these ligaments. The weaker these ligaments are, the more rapidly the spine is going to degenerate. So the good news is these are all avoidable things. Avoid all those things and you'll have a better spine ligaments. And get your vitamin C by eating your fruits and vegetables. Okay, let's see, what do I got here? Is there anything else I want to tell you about from this slide? We pretty much covered it. Lack of vitamin C is also called scurvy, weakening the ligaments. Oh, you know what else can damage them is advanced glycation end products that come from diabetes. But you also get dietary advanced glycation end products from eating high-fat foods. And guess what? There's all these, high-fat phonies trying to tell you nuts and seeds are such a great thing. They're also high in advanced glycation end products. I mean, they're nothing like fried meat, nothing like that. But still, they're kind of high, okay, compared to the other low-fat plant foods. Okay, you know what? We're going to call it right there. That'll be the end of part 2 of back pain, ischemic, and biochemical spinal degeneration theory of me, Dr. Rogers. I hope you're finding this helpful. I'm going to keep on going through a lot of really interesting stuff about the spine, how it all really works, and how you can do a lot of things to prevent back pain and to minimize it.